Hello everyone, and welcome to this special interview for JACC case report. I'm Miho Fukui, one of the associate editors of the journal. Today, I have the pleasure of speaking with Dr. Lu from Columbia University Urban Medical Center, who recently published an interesting case report in our journal. Thank you for joining us today, Dr. Lu.
Thank you for having me here. I'm grateful for the opportunity.
So to start, could you briefly introduce yourself and tell us about your role in managing this case?
Yeah, for sure. So my name is Ree Lu. I'm one of the third-year internal medicine residents here at New York Presbyterian Columbia. And this patient, she was actually admitted to one of the general medicine services, and so I happened to be the senior resident of her primary care team at the time.
Great. Now let's talk about your case. Could you summarize the key aspect of your case and what makes it unique?
Yeah, for sure. So our case describes a 44-year-old woman who originally presented to our center for shortness of breath, dyspnea on exertion, and she was found to have a right atrial mass with associated tricuspid regurgitation. And then further CT, MRI imaging of the chest, of the abdomen, showed intravascular extension through the IVC and then the hepatic veins. And we found that this mass actually originated from the uterus. And so we were working with the cardiology consult team at the time, and given the concern for obstruction, we thought that the best way to manage her was to maintain a slight net positive fluid balance for her to alleviate some of the possible obstruction. And then ultimately she underwent multidisciplinary surgical resection, and she's recovered quite well from that since then. And then the pathology showed that it was a rare benign growth known as intravenous leiomyomatosis. And I think what makes this case pretty unique is that it's just a very rare cause of heart failure in a young premenopausal woman.
Yeah, that's really interesting. So here are a few questions I'd like to ask about your case. So what was the most challenging aspect of this case?
Yeah, so I mean, I think that being at a medical center like Columbia, you have great medical teams, you have great consult teams and great surgical teams. And so, throughout the time that she was here, the care, the coordination, the communication was great. And she underwent a great surgery with relatively very few complications and recovered well. I think the thing that was actually the most challenging aspect of this case was actually coordinating the follow-up care. So at our medical center, we take care of many patients who are coming from underserved communities. In fact, most of our patients here at our center have Medicaid and Medicare. But the challenging thing for her was actually she didn't have any medical insurance. So of course, while we could take care of her inpatient, that outpatient follow-up was going to be a little bit more challenging. But again, I think we have excellent teams here. We had great social workers that were able to work with her, so that actually, like when she left the hospital, we were able to help her get set up with some insurance, and then she's continued to follow up at our center ever since.
And also, what are the key takeaways for clinicians who might encounter a similar case?
Yeah, for sure. So I think that one, for patients who have intracardiac masses, right? If there's concerns for possible obstruction and the patient's not like volume overloaded, it would be important to try to maintain the preload and maintain a slightly, I would say, a slightly net positive fluid balance. The second thing is that, for patients who have these intracardiac masses, it's important to do comprehensive imaging and other studies to really kind of find out what the source is. One thing that's actually kind of interesting about her case is that she actually originally presented at another center before coming by herself to our center. And based on the outside reports, they did the echo, which found the mass, and then they also did some chest imaging and saw the extension into the IVC, but they didn't do any other further imaging, so it wasn't actually clear to us like what this mass was and where it was coming coming from. And so, when we decided to get the comprehensive imaging, it was a bit of a surprise to see quite a large uterine mass, which is where this was originating from. And I think the last thing is that, in the evaluation of premenopausal women, especially if they have some kind of gyne history like uterine fibroids, if they are presenting with heart failure symptoms, this is something that should be on the differential. I'm no OBGYN myself, but my understanding is that, this disease, a lot of it is driven by hormonal changes. And so for premenopausal women, estrogen is actually like a driver of this. And they found that in patients who undergo estrogen deprivation therapy, like bilateral salpingo-oophorectomy or GnRH agonism, recurrence decreases, and also tumor burden can decrease in cases where the mass is not resected. So I think it's just important to kind of keep this in the differential in cases where you're looking at premenopausal women with heart failure symptoms.
Yeah, I completely agree with you. These are very important point for us. And also, were there any lessons learned that you'd apply to future cases, like similar cases?
Yeah, for sure. So, I think, one of the things that I kind of learned is, as part of a center where there's many different teams, the coordination of the care is pretty important. And especially since, we were involving CT surgery, OBGYN, vascular, and hepatobiliary, the communication with all these teams was pretty important. And so I think that was definitely one unique thing about this case, which was coordination of the teams. And of course, the other thing too is, it's not every day that you see a case of intravenous leiomyomatosis. And so, doing that kind of digging, looking into the data, into the research is important, because even though there's maybe not necessarily trials on these cases, there are definitely going to be case reports and smaller scale studies that can help kind of guide the management when there's not going to be really any particular guidelines.
Yeah, that's also very important point for us. So thank you for sharing your insight. So before we wrap up, do you have any final thought or message for our readers?
Yeah, for sure. I think just this is like a very interesting case, and I hope that you guys can take a look and enjoy this case and learn something from it. And I think just a couple last things is I'm very grateful. I think I'm being maybe a little bit sentimental as a third-year medicine resident, but I'm just very grateful to be part of this institution here at Columbia, where I have amazing colleagues who take care of patients and really care about the advancement of their care. And as a future cardiology fellow, I'm also excited to be a part of the cardiology community as we take care of patients with cardiovascular disease.
Fantastic. So once again, thank you, Dr. Lu, for taking the time to speak with us today, and to our audience. So be sure to check out this fascinating case report in JACC case report. You can find amazing images and surgical pictures as well. And he will present this case report in the upcoming presentation at ACC.25. So please attend the session as well. Thank you.
Thank you. Thank you very much.